Good afternoon and welcome to everybody that has joined us a few minutes early. We're really looking forward to this topic today of talking about families and how the opioid epidemic is impacting families and some practical solutions we are working on via partnership. We will get started in just a couple of minutes. Welcome everybody. We thank you for joining us today. Give us just 1 or 2 more minutes and we will get started. Okay, good afternoon, everybody. And thank you so much for joining us today for the first in a series of a theme that we're having for 2022 called Focus on the Families. It's a topic that is near and dear to our hearts and one that we really want to spend a lot of time on in 2022. We want to give everybody a few minutes to join in. So during that time, I'm going to go ahead and just give a little bit of background on relink.org for those of you that are not familiar with relink.org. And first of all, for those who don't know me, I am Barbara Campbell, the Executive Director of the Dalton Foundation. And the Dalton Foundation was very pleased to launch the relink.org project back in 2017 in partnership with the state of Ohio. It began initially as an attempt to kind of aggregate all the addiction recovery resources in one place for all 88 counties in Ohio. We started with some focus groups and some ideas, and it grew and grew and grew thanks to everybody's help, and became much, much better. Thank you all. We added in categories across the whole continuum of care. We quickly realized someone struggling needs more than just a detox facility, more than even just treatment. They need support from the community. They need a job. They need a license. They need so many other things. So we expanded the site. We also added in sources for reentry for those reentering society after a period in the justice system. And we've also added some resources in for human trafficking survivors. I want to introduce real quick our team on here. We've got Mr. Bill Pico with us, who is our data coordinator, who does an excellent job of keeping our data up to date and adding in new data. And Bill, I'm going to ask you to put your email in the chat, because if anybody has any questions throughout this about data, or if you have any data to share with us, which we'll talk more about, Bill is the person to reach out to. And I'd also like to introduce Sarah Capri, who's our statewide communications coordinator, who helps put all this together and does an excellent job just broadcasting relink.org and creating awareness about the site. And I want to turn it over to Sarah real quick, just to do a quick demo of, not demo, but just information about how to use relink.org.
Sure. Thanks, Barbara. So my name is Sarah. I'm the statewide communications coordinator for relink.org. We use the graphic that's on the screen in front of you on a regular basis to just give a good overview on how simple it is to use relink.org. That was the goal from the very beginning, to make it kind of just a few clicks and you are already at some resources that you can use to find help. So just in just a few steps, you click Find Resources Now once you get to our landing page of relink.org. And I'm going to help you guys skip that step and put the needs site that you see here on this Mac in the chat in just a little bit. So I'll pop the link in there for you guys. But you'll click Find Resources Now when you get to relink.org. From there, a page that looks similar to this one on the Mac here will pop up with all 6 of these categories, soon to be 7 once we add in our family data and family resources that we're discussing here today. The second step is to either select zip code or county. That's going to be your best way to find resources that are close to you and accessible. Once you choose either zip code or county, you are going to see that there's a magnifying glass next to either of those options, and you'll make sure to click that to repopulate the selection that you made for the area. And then you'll click on one of the categories below. So if you're looking for addiction services, basic needs services, emergency and crisis, reentry, you'll click, and then from there it'll lead you into browsing all kinds of options. So under the addiction category, there's treatment facilities and MAP programs and all those kinds of things. So it'll narrow everything down based on your needs, and then it'll pull up a large list, hopefully, of services that you can use in your area. If anyone has any questions going forward, I can leave all of our info, myself and Bill's and Barbara's, in the chat as well, so that if there are any questions or especially on usage for the website, we'll be happy to help you. Or if you know of any resources that you notice are not on the site, we are always happy to fill that in as well. So like I said, I'll put the link to the needs page, which is this page here, in the chat in just a little. Thank you.
All right. Thank you so much, Sarah. Yeah, if there are any questions, please reach out to us, especially at the info@relink.org email. Yeah. We sometimes forget to mention this because it's just in our everyday, but relink.org is free to use. It always will be free to use. It's just the goal of kind of taking everybody's Black Book in all these categories and putting it in one place so that everybody can access it. So we're just about making everybody aware of it and use it. If you ever need a demo, we do a lot of demos to different groups. We are happy to set those things up. Just reach out to us.
Yeah, the training these days are really common for sure.
Yeah, and that's great. So like I said, in 2022, we are really launching a new category for relink.org, and it is going to be on the families. We were fortunate to get some support from the state to work on a project for adding these resources into relink.org and also directly working with families. As we get started, now that we've had a few minutes for people to log on, we do want to launch a quick poll. It just helps us understand our audience a little bit better. It'll help Dr. Borland tailor his talk just a little bit. Sarah, do you want to launch that, or do you want me to?
Nope, I can do it.
Okay. We're just trying to ask if you are on the attendees here of the webinar, if you have a family member that struggles with substance use disorder, do you work with families directly, or are you find yourself in both or neither? So just take a second while I share a little background. So one of the things that kind of got to me, I'm just going to share a few statistics to kind of just set it up for Dr. Borland in the background, and I think probably a lot of you on this call, I see a lot of boths, know a lot of these statistics, but they're absolutely, heartbreaking that, there's more than 8 million children in the United States that have one parent, or adult with substance use disorder in their home. It's like about 1 in 10 children. So a lot of children some sources even say it's more, but I'm giving the most conservative numbers I can find. But there's a lot of children that are growing up watching this, and we know that as children watch this, they're more likely to mimic the behavior. And so a lot of organizations, the state of Ohio, are asking, what can be done to help mitigate this? What can be done to intervene? I know Dr. Borland talks a lot about, when you can intervene in a disease at an earlier state, you're much more likely to get successful treatment as opposed to intervening later on. So this concept of addressing the family, helping support the family, helping them cope with the reality that they're in, what to do, what not to do, I just think is such a really important topic. So, we had the opportunity to partner with Basecamp Recovery in Columbus. They've been doing some online training work to help educate families. And one of the things that really attracted me was, well, one, their work. I got to visit it and see it firsthand, and it was very impressive on the front lines. But I know there's so many organizations around the state that are doing that. They've also taken a very intentional effort to do a lot of online education for their patients and for families. And the approach they've taken that I really like is really small, bite-sized pieces of information that are easy to digest and easy to understand. I think I've looked at and taken some of these family trainings myself that are great. They're full of great information, but they're 4, 5, 6, 7 hours long. They can get a little complicated, and it's a little bit challenging for some families to navigate. So we thought of this kind of hypothesis of, what if we offer some trainings in small bite-sized pieces? Will that be enough to have an impact? And so that's kind of how this project got started and where we're going with this. So without too much ado, I want to turn it over to Dr. Borland, who's going to share a little bit about Basecamp and then a little bit more about this program and how everyone can get involved, because this is going to be an ongoing thing, not just a one-time thing today. So,
awesome.
Dr. Borland, I turn it over to you.
Thank you. And good afternoon, everyone. Thanks for joining us on a topic that's really near and dear to my heart. To give you a little bit of an idea of my background, I have a unique experience of really attacking the disease of addiction from multiple different levels. First off, I was raised in a home with alcoholism, a family full of alcoholism. And I remember thinking, as I was growing up, become a teenager and start to actually drink on my own, I can remember just thinking that, well, I'm smart enough that at some point in time, I'm going to realize I'm an alcoholic, and then I'll change and be okay. And unfortunately, this is a brain-based disease, which hinders our ability to make that identification, and it makes this disease likely to continue on, despite the fact that you had previous thoughts that if it was getting that bad, I'd stop. Following that, I also, to give you chronological, I went to Ohio Wesleyan for undergrad, got degrees in politics and government and pre-med. I went to Ohio University College of Medicine and down in Athens. And then I spent my 3rd and 4th year of medical school and my first 3 years of residency up here in Columbus with Ohio Health at Doctors Hospital, doing an emergency medicine specialty. During this time of my 3rd year, I just had completed my 3rd year of residency, and I was actually taken out of the emergency room because I had been caught stealing pain pills from a patient. And so this gives me a very unique experience. I went to treatment immediately the next day, and I ended up having a successful recovery, not necessarily because I'm a doctor, but because of the fact that as physicians, we are required to have the highest level treatment, the highest quality treatment. And so it was really a blessing for me that I was put in that position because I received fantastic treatment. Throughout the process, there were a lot of things that happened in my life. I was charged with a felony and pled guilty to one. I lost my home. lost my car, lost my retirement, lost my medical license, lost my DEA license, and ultimately couldn't really work a job because of the felony. My first job out of treatment was I was a telemarketer, and that was the only thing that I could do. And when I ended up pleading guilty to the felony, I actually got fired from that job. So what a day being fired from my telemarketing job. In 2018, I had been in recovery at that point in time for about 4 years. I had been completing all of the requirements for the State Medical Board of Ohio so that I could potentially get my medical license back. Through all of that work, I ended up getting my license back in 2018, as well as my DEA license back in 2018, and ultimately started basically a new life. Knowing the struggles that I went through with my own alcoholism and drug addiction, and recognizing that we are dealing with an opioid epidemic that unfortunately we are not winning. So I felt that my time was probably better served in the world of addiction medicine. And shortly after receiving my license, I was recruited to start a treatment center up here in Columbus, and then was actually asked to start a second treatment center down in Portsmouth after that. And then that brought me here to Base Camp Recovery Center in downtown Columbus, Franklinton, where we started a very large treatment center that is based on the disease model and the new medical models of the disease of substance use disorder. It's a chronic disease, sort of like diabetes and any other diseases where it's chronic, progressive, and oftentimes fatal. And our treatment really relies upon how you treat other chronic diseases, which includes education, making a self-diagnosis, therefore being more likely to make self-treatment, and ultimately taking the responsibility on for that own person's management of their treatment further down the road. So through that experience, Base Camp has really grown to be a company that is intentional about those who are struggling, who are unlikely to receive care. Because of this, we focus on the hardest hit populations. We intentionally are focused on the population of people leaving incarceration who are not on MAT. We know that there is a significant risk of death for those who leave incarceration on without any MAT. Their tolerance has been lowered. They haven't received really any treatment while they were in there. And so we should expect that they're going to leave incarceration and go back to using drugs. We wouldn't expect a diabetic who requires insulin to go into jail and then when they leave, not require insulin anymore. It's unfortunately, when we look at it as a disease, it makes it so clear how treatment, quality treatment, is so necessary for substance use disorder. Other populations, we really have a passion for the LGBTQ populations, transgender populations, very, very high risks of lethality in these populations. And so we really have created an environment that is welcoming to all. We also are one of the few locations where if you have no insurance whatsoever, you will not be turned away. You will be seen immediately, just like any other patient. And if you are unable to pay, we will never ask you to pay. That's something that we believe in, particularly from Robin, the co-founder of, actually the founder of Base Camp Recovery Center, and my business partner, Rob Gressel, who was an ER doc for 10 years at Grant downtown. Really his belief that we both sort of come from an emergency room sort of setting, which means that if you show up at our door, we're going to be ready to jump for you. We're going to be ready to get things moving and take care of things right away. With this disease, we talk about you have essentially minutes to hours when a person comes and asks for help. Therefore, we don't have the ability to ask for you to schedule an appointment 2 weeks down the road, or that you need to come back tomorrow, because oftentimes this may be the only opportunity we have with this person to get them safely into recovery, or on medications that could potentially save them from lethal overdoses down the road. So I'm going to shift now a little bit towards why the family. Why would we? It seems like we have our hands full with providing treatment, but there's this other part that is so important with substance use disorder, and that is how do the family, the loved ones, the significant others, how are they impacted by this disease? It's sort of not like a diabetes or not like an asthma, where yes, it's going to have some impact on a family, but substance use disorder often involves significant impacts in the family, which can be very difficult to understand. What do I do? How do I handle this response? And with that lack of information, I think that it causes family members to really, really struggle through this process. And so we feel that the treatment of the family members is just as important as those with substance use disorder. There's not a lot of great education out there. And so we've sort of taken that on. Particularly, we provide a family lecture series on the weekends that is specifically for family members, loved ones. On every other Sunday, we do an Ask the Doctor, sort of like this webinar is, to where family members can come in and they can ask any questions that they would like. And then once COVID really hit, we weren't able to provide that anymore. And it was so valuable to family members and friends that we said, we can't just do away with it. It can't just disappear. And so that sort of started us working and walking down the pathway of how do we create something that we can get out there similar to what we were doing on the weekend family programming. It was great that we had a connection with someone like the Dalton Foundation and Relink. They have fantastic resources, and it's really been a blessing for us to come into partnership with this, because I really think with their help, we have actually created a product that I think is insightful. It provides a lot of education, and I think it helps family members to understand a very difficult concept, which is the disease of substance use disorder. And so I appreciate Relink and the Dalton Foundation's partnership in this. And then finally, I wanted to talk about how did we sort of get to this point of focusing on families or going down this pathway. The series is really created to do sort of a stepwise fashion of 4 parts. And that is to first identify the disease, or first address the stigma associated with the disease. Second, identifying the disease. Third is understanding the disease. And the fourth is codependency, how to remain independent, and how to talk about things like support versus enabling, setting healthy boundaries. And so those areas, to give an overview, the first being stigma, is that right now what we notice at Basecamp in particular is that the DSM-5 criteria, which is used to make the diagnosis of substance use disorder, has 11 different criteria. To get a diagnosis, you have to have 2 to 3. That's a mild diagnosis. 4 to 5 is moderate, and 6+ is severe. And unfortunately, 95% of the patients that come to us for their initial assessment, they have 11 out of 11 of those criteria. They've had 11 out of 11 for some time. And in fact, the 11 out of 11 doesn't even really characterize where they're at on the spectrum. And I think that certainly stigma has a role in this. Number one, no one wants to be labeled as an alcoholic or a drug addict or someone who's struggling with substance use disorder. And so we sort of try and create reasons for it not to be those. It's just Johnny's depression, or Timmy broke up with his girlfriend and it's a phase. And we hold such a stigma that it's not until you are in jail or homeless that then we're sort of at that point comfortable saying, okay, maybe they have a problem with drug addiction or alcoholism. When in reality, the diagnosis could have been made oftentimes years prior to that. Stigma affects the healthcare system, unfortunately. I think that there's true discrimination against those struggling with substance use disorder, and opportunities for high quality evidence-based treatment are few and far between. Secondly, identifying the disease. This helps sort of take the stigma out of things, because now you're using just factual data, as in how many criteria do they meet, and is that enough to make a diagnosis, not make a diagnosis. It's nothing morally wrong with them. It's nothing that they're a bad person. It's simply just, here are the criteria for this disease to make a diagnosis. And if you're seeing behaviors that resemble these criteria, you probably have a good idea that that person probably needs treatment at that point in time. With understanding the disease becomes the understanding gives you somewhat of a comfort to understand that this is a biological, physiological process by which a person has an abnormal response to dopamine, which is the neurotransmitter in the brain that is used for the reward cycle. Evolutionarily, this reward cycle has been used to promote survivability. Things that increase survivability, you receive dopamine as a neurotransmitter for, so that you will keep doing them. Those who have substance use disorder, unfortunately, this system is intact just like those without, but they react very differently when a drug or alcohol is introduced into the body. They get a dopamine surge from that is 10 to 100 times more dopamine than the normal behaviors that people get, whether that be food, sex, community, raising a community, raising children, hygiene. And so because of that, those dopamine producing behaviors actually become deprioritized, and the drugs become the top priority. And so what do we typically see when we're thinking about a drug addict or alcoholic or those struggling with substance use disorder is a person that oftentimes isn't really interested in sex. They go without eating. They, instead of being in community, they actually isolate. Instead of focusing on hygiene, they typically do the quite opposite. And when it comes to nurturing and parenting, oftentimes those skills are sort of lost in the chase for the substance. And so understanding this begins to let family members and significant others view this as this is the physiological reason that they're going to behave in these ways. They are going to lie and cheat and steal and try to manipulate simply because of the biological mechanism that tells them the more dopamine that we get, the more likely we are to survive. This is an important concept to understand because humans want things to make sense. And if we look at someone who's basically running out in the street and getting hit by fire trucks, and then going in the hospital, getting better after months, and then they come right back out and they jump in front of another fire truck, that doesn't make sense. It just doesn't make sense to rational thinking human beings. But it does make sense if you view the fact that the brain is focused solely on the most dopamine it can get. And it thinks more dopamine equals more survival. So it is the most important thing to a person with substance use disorder's brain is to continue to use drugs because it believes survival is based on that. And going through this process, that's why, despite the fact that maybe they are deteriorating right in front of your eyes, in front of your loved one's eyes, that they will keep doing the same behavior to the point where they might be on their deathbed. And the last thing they think of is, I should probably go use drugs. The brain is confused. It believes the drugs lead to survival when in fact it's the exact opposite. The behaviors associated with drug use are definitely not survival promoting. So that being said, when you combine in the physiological aspect of the disease, we also see that it's not family members who aren't not providing a good environment for a person to succeed in. It's not a family member who caused this to happen. It's not because they don't love you. It's not because that you've done something wrong in their life. It's simply because of a biological process in which their brain gets confused. I think it's important to understand these ideas because over a period of time, I think a lot of guilt and shame has been attributed to those around people struggling with substance use disorder, trying to figure out what I did wrong. When in reality, it's not that at all. It's a biological process. It's a disease process. And so how do you view support versus enabling? A common concept when we talk about families. Well, support would be any activity that increases the likelihood that a person with this disease goes to treatment. That's support. Providing any help necessary to get them into a treatment center. What would be enabling would be anything that makes it less likely for them to go seek treatment. So maybe it's providing a warm place for them to stay and food. It seems like the right thing to do. It seems like the nice thing to do and the caring thing to do. But ultimately, that probably decreases the chances that they're going to go to treatment because their situation isn't that bad the way it is. So the other part is setting healthy boundaries, allowing family members to recognize that there is sort of a line between what a person can and cannot do. And that line actually is designed to keep both parties safe. For instance, a healthy boundary might be that you have to be home by 10 p.m. In order to stay here in our home. That not only protects the substance use disorder person, because it gets them in the house, it gets them into a safe environment, it gets them into bed, and it gets them into bed before poor decisions can be made later in the evening. But it also protects the family because what happens if they don't come by that 10 o'clock time? Now, family members are up the whole night long wondering where are they at? What have they been doing? How are they going to make it in? Are they? And that's not the way that this should affect family members. So boundaries are very important to help keep a healthy relationship between loved ones and family members. Finally, the topic that I want to talk about and the ultimate sort of outcome that we're really looking for is independence. When a family member or a loved one can live a life that is independent, then they are able to work with a person, provide support that's only directed at increasing the likelihood that they are in treatment, but at the same time, not allow behaviors or words or actions that are not relevant to a person getting into treatment, to allow those to sort of fall to the wayside. Understanding that when a person is in active use, they are going to say and do things like that, not because they don't love you, not because they're bad people, but simply because they're very, very sick at that point in time. And so it's important for family members to look at your lives are equally important to theirs. And so it's possible to not be in a codependent behavior in which every action and behavior of the person with substance use disorder negatively impacts the loved one. If a person continues to use, they are going to get sicker. And if a family member is codependent on that person, they are going to get sicker as well. So that's how this cycle can perpetuate itself to the point where the family itself is so impacted that they are also very sick. Their lives are not happy lives. They're not living peaceful, potentially retired lives that they thought that they would be living. How many grandparents and grandparents are raising children now? How many single parent homes related to the impacts of this disease? The effects are so far and wide that if we focus on getting family members healthy and getting family members to a point where they can be independent, yet still supportive, but not enabling, I feel like we can at least decrease the magnitude felt by this disease into the general population, as well as setting boundaries and providing opportunities that encourage people with substance use disorder to get into treatment early, to recognize the disease process, to not be afraid to let someone know, here's what I'm seeing and I'm very concerned. And I think that the best thing at this point is that you go have an assessment, that you get into treatment, and being comfortable having that conversation rather than sort of protecting them from ever being labeled as a drug addict or an alcoholic. So the video series that we've created, and I'll show you here a little bit, is called Begin Your Climb. It can be accessed at beginyourclimb.com. And this is the landing page. So this is beginyourclimb.com, which you can see up here. And this is an addiction education platform guiding you to new heights of understanding in addiction disorders. This is the specific family course designed for families, loved ones, significant others. And the way that you access it, this is completely free. There's no charge for this program. You click here on the families course to get started. And you will create a login and a password. There's no credit card information required. There's no payment or anything. And to be honest, you can also be anonymous if you want to by whatever login email that you may choose. So I'm going to go to my account so we can see. This brings up the courses. There's only one course right now. We've designed it to be as simple as possible for you. And if we open up that course, what we see is here's the syllabus for the course. There's a welcome message. There's some initial information. There's a pre-assessment. And then there are 4 different modules here that are short and concise, as in, I believe this one's about 7 minutes. Some of the others are between 10 and 13 minutes. So they're really doable in one sitting. And to sort of take you through the process that I mentioned. So here we're going to deal with stigma. Here we're going to deal with identifying the disease. This one is going to be all about understanding the disease. And then finally, this is going to be about how parent, family members, significant others can live in a world with those with substance use disorder, but not necessarily have to be fully impacted from the disease. After you complete those, there's a post-assessment and there's a satisfaction survey. Please, if you're going to do the course, fill that out so we can make changes as we go along. And then there's also a certification that you can print that shows that you completed the entire course. And so this is available again at beginyourclimb.com. It is free. There are no requirements. There's no credit card that you have to put in. There's no charges later down the road. It is purely free. And I think it really gives a great start to understanding the disease process for loved ones, as well as those who may be struggling with substance use disorder themselves. They will also gain a lot of information from this as well. So that is the course that we've created, and Relink has been, and the Dalton Foundation have been putting this out there into the treatment center world and the family and those struggling with substance use disorder world. And we started to have quite a few people taking the course and enjoying the course. So I look for that to continue. And if so, we have many, many more classes that are already made. And so we'd love to expand on that if we have enough support. And ultimately, I think that's about what I have.
Thank you so much, Dr. Borland. Every time I listen to you talk, I feel like I learned so much. You know, I hear it, I know it, I understand it, but it's just so good to hear it. And thank you for sharing it so clearly and concisely. And if you have any questions, please type them either into the Q&A section or into the chat section, because we'd love to have Dr. Borland have that opportunity to answer those questions for you. Like I said at the beginning, our goal, and this is just a little project, we're doing a 6-month project on this, but the overall goal is how do we get the information out to help reduce the stigma? How do we get the information out to help not only those struggling with substance use disorder, but those that are the family members that are with them? And again, like Dr. Borland said, there's so many other topics we could add to this, regarding prevention of family members. But we wanted to do something that was bite-sized, that we think people will pay attention to. I don't know if that's the right phrasing, but I think sometimes when someone asks you to take a course, sometimes it can be a little long, and you can be overwhelmed with stress in your life, and you just think, I cannot do that. And we wanted to just try this experiment of, hey, can you do it in bite-sized pieces and show learning from beginning to end? And does it help people? Does it help people cope and deal with what they're going through? So again, that's the overall goal.
For future webinars, to give you guys kind of an update, future webinars, we will really have it to be sort of an Ask the Doctor type of style, in which you can ask any sort of questions that you want, and that we will respond to them as best as possible. This is very much like the family group that we do on Sundays here at Base Camp, where family members are allowed to walk in. We typically allow them to put up 10 or 20 topics that they'd like to talk about. And then we systematically go through each and every topic, discussing how it relates to these concepts. And so at future webinars, bring your questions, bring lots of questions, and don't be afraid to ask them, because I guarantee that someone is going to learn something from your question just in hearing it, how it is explained. And so don't hesitate to ask any question, no matter what you want, what you think. I will do my best to explain it, or I'll make something up and it'll sound right.
That's the medical school model.
Yes, it is. Exactly. I'm also putting my email in there right now, so that you guys can, if you have questions that you want to send me, you can also send those ahead of time. Or if you like to chat about something, I'm always excited to talk about recovery and moving forward and the treatment of this disease. So hit me up. I normally am pretty easy to respond to. So.
Yeah, that's been our experience for sure. We did get one question that came over from Amy saying, what are your thoughts on MAT for a young mother with substance use disorder? Is that sustainable?
Yes, it is sustainable, it is supportable, and there's been great literature that recently came out regarding the topic of breastfeeding while on MAT. So what the studies really looked at was, would the child be more likely to go into neonatal withdrawal syndrome because the mom is on Suboxone, and then when they get taken away from the mom, now they have to go through this horrible withdrawal process. And the study found that in actuality, it was compared to use of other drugs, the withdrawal syndrome was significantly less in neonates who were on Suboxone throughout the pregnancy. And it is heavily supported that the number one item that decreased the neonatal withdrawal syndrome risk was breastfeeding of a mother who's still on Suboxone. And so it is absolutely doable. And I like to come back to sort of the emergency doctor training of, well, what's the alternative? We have a disease that we know includes cravings, significant cravings that make it almost impossible not to use drugs without some form of MAT. So if we do not provide MAT, the chances of them utilizing other illicit substances that are far worse for the human body and far worse for the fetus is a risk that I'm not willing to take, especially given that with fentanyl and stuff that's out there right now, one use could be your last. And so absolutely, I encourage the use of MAT for pregnant mothers throughout their entire pregnancy. The risk of overdose and death, or the risk to the fetus of being exposed to very, very significant neonatal withdrawal syndrome is from street drugs that are not controlled well, and they are up and down, up and down, up and down the whole time, versus a slow state of with Suboxone or other forms of MAT.
Thank you.
Yeah, and I see someone put out there, number one cause of death of new mothers in the first year of substance use disorder, and that is absolutely, oh, it's from Stu. Thank you, Stu. It is absolutely true. One of the areas that we talk about is that within the past few years, it used to be for people ages like 15 to 30s or so, the number one cause of death was trauma. And so we have all these big trauma centers and helicopters and these ideas that if we get you to a trauma center, your risk of death is decreased. And we had all this focus, but recently, substance abuse disorder and overdose has taken over the spot for those in that age range as the number one cause of death. And so my argument is, if we'll send helicopters all over the place to get you to a level 1 treatment center, trauma center, why don't we have level 1 addiction centers? This is the number one cause of death for our younger population. We do all of this. If someone's in a car accident, we're going to send a helicopter to pick you up in Marietta and bring you all the way up to a level 1 trauma center here in Columbus. But if you walk in that same level 1 trauma center and you tell them that you have an addiction to opiates, you're very, very likely not to receive a diagnosis of substance use disorder, and you're very likely not to receive any information about treatment whatsoever. I think the studies show that it's about 14% of people who go to the emergency room requesting help actually receive some sort of treatment recommendations and diagnosis. So I'm going to keep pushing for it. Level 1 addiction center. I'm just going to keep talking about it, and hopefully I can will it into fruition.
Oh, thank you. There was another question that came over from Terry saying, are there other base camp recovery sites or only in Columbus? And with a follow-up question, do you all use Vivitrol there?
Fantastic question. Actually, we signed a lease this morning for a second location. It's going to be closer to the east side of Columbus. And we should be opening, it's actually fairly turnkey. So we're hoping to have it open within the next month. And do we use Vivitrol? You bet. You bet. Vivitrol is, particularly in our incarcerated population, Vivitrol is fantastic because although there are drugs in prison and jail, they are less likely to have used any sort of opiate in the previous 10 days. Our patients that come right up off the street, it's very difficult to use Vivitrol for them because they've been out using opiates day in and day out. And to ask them to go 7 to 10 days of complete abstinence so that they can then receive Vivitrol, which is an opiate blocker, without going into significant withdrawal is a huge ask. And most people can't make it that 7 to 10 days. So our incarcerated population, definitely with Vivitrol, and our alcoholic population, absolutely Vivitrol, great medication, love it.
Thank you. And thank you, Stuart, for posting that article that I think Dr. Bourne was referencing about the new moms. So thank you.
We also provide Sublocade. I'll give my shout out for that. Sublocade is a newer medication that is a 30-day Suboxone injection. And so the buprenorphine that you receive in Suboxone, which is a opiate agonist and an opiate antagonist, meaning when it binds to the receptor, it fires the receptor some, but it also blocks fentanyl and other opiates from attaching to the receptor. So it's also an antagonist. It can be a 30-day injection that actually lasts up to 45 to 60 days. That takes away the person having to carry around their Suboxone medication all the time. It takes out of the equation of diversion of Suboxone or selling of Suboxone. And it's a great peace of mind because it really breaks the habit of, I have to always have my medicine, take my medicine every day. Where's my medicine at? Do I have enough? Will the pharmacy be open? All of those things that can lead to instability and being able to just relax in recovery. It takes a lot of those away. So Sublocade is something we definitely recommend, particularly those going into sober living or recovery houses where you don't want maybe 5 people there with all this Suboxone around. They, if they're on the Sublocade shot, you don't have to have any Suboxone in the house.
Those are really good insights. A lot of things that I hadn't really thought through all those details, but you being right there on the front lines and having seen so much experience, it's so valuable. Are there any other questions? Oh, here's one that came in from Carolyn. Does Sublocade provide the same pain relief as daily Suboxone intake?
It does. It does. I can tell you, we have several. Well, actually, we have quite a few patients on Sublocade, and some of them were on Suboxone for the mutual benefit of some pain control as well. And they report that it is absolutely similar. The pain control is absolutely similar to the daily use of Suboxone. Great question, though. Fantastic.
All right. Well, oh, here we go. Another one. Can a resident from other communities come to the Columbus facility? Yes, absolutely.
The services, I guess I never even really got to that point of the services that we provide. We provide ambulatory detox. So a person who is going through active withdrawal can come here and be treated immediately with medications to help them not be in active withdrawal. You don't spend the night or anything. It happens typically during the day, but particularly for most opiate users, we can get you induced on Suboxone and get you out of withdrawal in just a few hours. Then we also provide partial hospitalization, which involves groups 5 times a week, a couple of individual counseling sessions a week, a doctor visit, a nurse visit. We have IOP, which is groups 3 times a week, counseling, doctor's visit, nurse visit. And then outpatient, which is group 1 time a week, a counseling session, and any other services that you may want, whether it be case management. We offer full array of services, particularly with case management. We'll help you get driver's license. We'll help you get insurance. We'll help you get food stamps, get living situations set up. And so we offer a full array of services here. And yes, you do not have to be from any particular area or community to come here.
All right. Thank you again so much for taking the time, Dr. Bowen, to be with us today. Are there any last minute questions from anybody? Otherwise, as we kind of alluded to, and Dr. Bowen had said, we're going to have some Ask the Doctor type webinars that we encourage both family members, anybody struggling, people that are working with those that are struggling with addiction. I know that many people on the webinar today fall into that category where you work with people. We would ask, if the training can be of use to you or any of your clients, please use it, test it yourselves, provide feedback. I think all those things are really important as we try to learn from this process of trying to provide education in little smaller pieces to see how valuable it might be.
Absolutely. Absolutely. And I appreciate you guys putting the work in this field. It's a field that's near and dear to me with my own struggles and now in my own recovery. And so I cannot thank you enough for the work that you put in. And it's such a rewarding field to be able to see someone's life really, really turn around. And so I appreciate all the work you guys do.
Yeah, I mean, all the social, everyone on the front lines, man, my heart goes out to all of y'all. So thank you all for all you're doing. Thank you, Dr. Borland, and the team at Base Camp and all the other treatment facilities around that are doing this really good work on the front lines. So we view our role as just to try to get the word out and get as many people, reduce the stigma and get as many people the help they need as possible. So thank you again, everybody, for joining us, and just stay tuned. We'll announce some more upcoming webinars. Probably one a month will be coming on this topic. So thank you all very much.
Thanks, guys.
Everyone.
Enjoy the rest of your day.